Good day, everyone. My name is Drew Voitel, and I am the Senior Project Associate for Education and Outreach at CAQH Core. It is my pleasure to welcome you today to our webinar on electronic healthcare attachments, the second webinar in a four-part series. And today's webinar, we will focus on pilot and implementation case studies. Before we begin, I would like to mention a few logistical items. You can download a copy of today's presentation from the caqh.org website, navigate to the Core pull-down menu at the top of the caqh.org welcome screen, and select the Core Education Events page. A link to the PDF version of the presentation can be found under the listing for today's webinar. Also, a copy of the slides as well as the webinar recording will be emailed to all attendees and registrants in the next 1 to 2 business days. We will save time at the end of today's program to respond to audience questions, and you are encouraged to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. We do ask that when you submit your question that you please identify the type of organization you are with so that we can give you a more applicable response. We would like to thank our partners for joining us today. Joining us, we have Leora Alschuler, President and CEO of Lantana Consulting Group, Mary Lynn Bushman, Senior Business Analyst with National Government Services, and Nicole Smith, Vice President of Operations and Government Services with Vine Corporation. Our session today will start with an overview of CAQH Core's work on attachments before we move into why electronic attachments are needed. We will then learn about the different case studies being presented, and then we will finish off with questions from you, our audience. And so we will begin today's program with an overview of CAQH Core attachment work from CAQH Core Associate Director, Robert Bowman. Bob?
Great, thanks, Drew. And just as Drew mentioned, we do want to provide an overview of what the work that we've done here at CAQH on attachments. So moving into the next slide, we do want to basically set down some definitions that we've seen within the industry and how they're used. And basically, claims attachments are considered supplemental documents providing additional medical information that cannot be accommodated in the claim format, or common attachment types include certificates of medical necessity, discharge summaries, or op notes or reports. NCVH extends that to supplemental documentation or additional documentation needed about a patient to support specific healthcare related events using a standard format. So again, with the different types of data that's required and different types of attachments that are required to facilitate different use case examples, which include claims and reimbursement, prior authorizations, referrals, and audits. Moving on, we can look at some of the work and background of the scope that CAQH has done to date. And we've been kind of working through the attachments process and understanding the entire environment within the healthcare industry, both on the administrative side as well as the clinical side, that has taken place over the last few years. We've regularly attend and monitor the different standard setting organizations meetings. We do help support the evolution of the CAQH index to track claims attachments, working with the health plans and providers that report information to the index. So we're including that information, and we'll have more information about that in just a few moments. We have conducted an assessment to identify the business needs, the data content format requirements, the infrastructure, and the priorities of exchanging administrative attachments. We have held a series of listening sessions with over 300 participants to continue that dialogue, to discuss the different trends that have taken place, to look at the different types of data that is being conducted through attachments. And findings from this indicate that a majority of entities are still using paper. They still provide a lot of their clinical data on a claim or other administrative transactions, and that they use a variety of formats, some of the most common being JPEG, PDF, TIFF, and Word. However, we are seeing changes through the industry, and we'll learn more about that in today's session. We do want to make sure that everyone is well aware that CAQH Core has been designated by HHS as the operating role authoring entity for claims attachments, which is why we're conducting this series of webinars this year, as well as continuing our environmental scan of exactly where the industry is, and perhaps even look at the opportunity areas where operating rules related to attachments should go. CORE has stated our public support for an incremental phased approach that uses flexible operating rules to move the industry forward. Again, from paper to electronic documents. That's our intent. If we can move to the next slide, we can also see that we have to ensure that there is alignment between CAQH core mission and goals as we approach the realm of attachments within the healthcare industry. Again, the lack of an attachment standard is a challenge for both providers and health plans and their supporting entities, clearinghouses, and software vendors. But given our mission and vision, we need to be able to solve some of those challenges, and that is a part of our critical goal this year moving into next. So using our integrated model, we are determined to work to provide solutions and guidance with or without a mandate from the federal government. So it is a challenge, but we are definitely well equipped to work forward and move the industry forward. So regulations for the administratively focused attachments have yet to be issued, so again that is a challenge with us. Section 1104 does require the adoption of a standard. There has been some regulatory activity related to the clinically focused attachments, but still not action on the administrative side and really in a holistic approach. So again, claims attachments work moving towards HL7, a standards development organization, looking at what that particular organization and what they're doing is going to be very important as we move forward. However, there's still a wide range of opinions on what standards would serve the industry best regarding electronic attachments and the approach that we go. You know, what are the steps that we take to get to a fully automated, fully electronic attachments process, workflow, and how that supports claims adjudication and some of the other use cases that we just mentioned. We do want to go back to the 2016 CAQH index report, again just published this year. Based on the data that we see within the latest index report, 5.4 billion transactions were reported on the adoption of electronic claims attachments transactions for the very first time. And some of the key findings are going to be important for us as part of that level set and part of our environmental scan. Only 6% of healthcare claims attachments are submitted to health plans electronically, very low percentage. We see that the adoption of electronic claims attachments is isolated. All plans still report that they receive paper claims and paper claims attachments. They receive paper. No plan doesn't receive paper. The labor alone that we've been able to tabulate and calculate within the index is that over $500 million could be saved as we fully implement electronic claims attachments. Participating health plans self-reported the only use of X12 standards for claims attachments at this time. Again, we are seeing changes and hopefully today we'll see that it's not just anecdotal. There are plans that are moving forward beyond just X12 transactions. So again, there's a wide range of opinions. We're making sure that we're part of the industry, that we're plugged into hearing all those different opinions and ensure we're bringing that forward through our environmental scan work. Last but not least, we do want to ensure that what kind of business direction and drivers are there within the industry, and we ensure that we align ourselves to those particular components. Now, some of that does include the healthcare standards that are available, X12, DICOM, HL7, as well as industry neutral standards that are still in use and that are really important for our constituency and our stakeholders. So some of the key considerations that we need to consider are ensuring that the operating rules work with the HIPAA mandated standards as well as industry neutral standards. We do not want to repeat anything or contradict anything that's within those standards. Again, that's exactly what operating rules do. We want to ensure that we align the operating rules not only with the administrative transactions, but also look and see what's going on in the clinical world and the clinical standards. Again, it's very important because of EHR, meaningful use, and the incentives there. Addressing the most common business scenarios would also help improve in the return on investment. We don't want to look at and just focus on the small one-offs. We want to make sure that we address things that have a global fix to some of the main problems that we have. Part of the nature of operating rules is also to fill gaps because many of the standards are very flexible. They can move around. They can ensure a wide range of possibilities, and sometimes that wide range allows for implementations to slow down because suddenly the standards become a little, for all intents and purposes, a little proprietary, and which is exactly what they shouldn't do, and what many organizations are working to ensure that the standards are just that standard. So sometimes the operating rules can fill those gaps to ensure that the standards and the need for the standards, the business drivers and the directions are there for adoption. And lastly, building off the existing momentum to encourage feasible progress. And we're going to hear some great case studies today where entities have made progress in adopting electronic transactions. With that, I'm going to hand the call over to Drew for our first polling question.
Wonderful. Thank you very much, Bob. And so this brings us to our first polling question of the webinar, and we'll have 3 of them today. And how this will work is I will show you the polling question right here. I'll read the question, then on your screen you'll see the poll appear where you'll be able to answer directly from there. And this question asks, which functional need is a top priority for your use of attachments? And this is a select all that apply, because there might be, and most likely is, more than one. So let me launch this poll, and you should see it appear right now, and we'll just pause for a brief, maybe 15 seconds for everyone to respond. And Bob, maybe I'll have you comment on some of the responses that we get here. Take just a couple more seconds, and we'll see what people register. And I see we have about 210 people on the webinar. About 72 have voted, so I will close the poll and share the results. Okay, so what do we have here? Well, the largest percentage of those that logged a response, claim and reimbursement, was the largest percentage here, 59%, followed by prior authorization and referral, 40%, and then another large percentage, 38%, indicating all of the above. And again, this was select all that apply, so we'll have to dig into the numbers to find out exactly how people specifically answered. But Bob, what do you make of these results?
I think it's spot on what we would anticipate, that claims is going to be a majority of the interest that folks have, and is probably going to be a significant use case as we move forward for attachments. But not far behind is prior authorization, in particular because of the manual processes that we know that providers have to go through to submit prior authorizations for approval. So again, thank you for completing the poll. This is really helpful data.
Wonderful. Thank you very much, Bob. And so now we will continue with our program with Leora Alschuler, CEO of Lantana Consulting Group, to help us understand why electronic attachments are needed. Leora, go ahead.
Thanks very much, Drew, and thank you, CAQH, for conducting this. It's a great opportunity for people to begin to get up to speed and understand the movement here towards one method. You can advance the slide. Moving towards one method across the industry for all types of electronic attachments. So let's dig in. The data on ROI, you'll hear something from in relationship to the case studies that we're presenting about their actual findings for ROI, which are very interesting. In general, I think we can associate them, sort of group them in 3 buckets around turnaround time, reducing time to payment, reducing the number of denials, just sheer cost of materials, which do go down significantly, and labor savings. We've dug a little bit into how this distributes down across different stakeholders and for different types of electronic attachments. And it's interesting that in the early stages with certain approaches, the benefits seem to accrue pretty substantially across all stakeholders. And then as you move up in sophistication, you have to look at that a little more closely in terms of who actually is going to get the ROI. But what's very encouraging is the ROI statistics and data that we have, and you'll see that in specific cases in our case studies. So what you're seeing on the slide here is a graphic illustrating different approaches that people are taking to send electronic attachments today. And I did some quick math while Bob was speaking. With the 5.4 billion transactions of attachments sent today, if 6% are done electronically, that's low, obviously, in terms of creating a critical mass, but it's a significant start. By my seat of advanced math here, that's about 300 million attachments being managed electronically today. So looking at how people are doing that is critical. What I'm going to speak about as standards is defined by those standards that were represented in the testimony from stakeholders to hearings held last year from the National Committee on Vital Health Statistics. And the level of consensus there was extremely high in certain areas, and that was particularly to use the healthcare-specific standards for the data in attachment, where there was some discrepancy among stakeholders, I would say, around the edges, a little lack of focus around the edges of the consensus. It was around the mechanism to use to convey that, whether it should be fixed on a single protocol for simplicity across the industry, or whether there should be flexibility in the manner in which the attachments are exchanged. So you have a great mix of case studies coming up to show you both approaches doing electronic attachments using non-healthcare standards like PDF, and then using the consensus standards as reflected in the testimony to NCBHS, and then NCBHS letter to the Secretary that recommended the use of the HL7CA as the attachment, and some degree of consensus around the protocol for transport. The letter also indicated that, advocated and recommended to the Secretary that the approach taken be consistent with the other national programs, citing the incentive programs for electronic health record adoption, and the newer programs for quality reporting, MACRA and MIPS. So the case studies 2 through 5 are showing a progression of a variety of approaches and a progression in the sophistication of adoption of those standards. And the first case study is taking an approach that uses the non-healthcare standard PDF for the attachment and the Connect protocol. So a little bit of preview about the case studies. You can go to the next slide, Drew. We do have some metrics on ROI which are encouraging. Note that these are from provider offices. They're based on studies that the Milliman from 2006 and then the CAQH index from last year. They're relatively close, actually, if you consider the time difference and the margin of error. And they indicate a certain return per month for a projected volume. And where we go with this in terms of establishing ROI, of course, we need the other part of the equation, which is how much is it going to cost to get there. So there's a lot left to be discussed and discovered. And I think you can go to the next slide, because we'll really be looking at the ROI from the case studies in a minute. So why now is a critical question. And I really have to agree with Bob's statement that short of a mandate, there seems to be a gathering momentum in industry to move forward and adopt a single method across the industry based on the economics of the situation and the readiness of time. So what this slide illustrates is that the healthcare industry standards have really come down in complexity. If you look at that effort starting 20 years ago with HIPAA, those proposals were fairly far removed from the everyday process of collecting and organizing and managing healthcare information. There has been evolution through that in the direction of not only simplification, but as you can see in the graph, converging with the increasing sophistication of clinical information systems, so that today I think we're really at this sweet spot, and we have an exact match between the standards required under meaningful use and the standards that the healthcare industry has reached as a consensus point for electronic attachments. We have the ability to grow forward and increase the sophistication, and I think also reduce the simplicity of this with an evolutionary path through those standards. But that's maybe another topic. I think you can go to the next slide. The approach that the healthcare industry has come to consensus on and expressed is consolidated in this supplement to consolidated CDA. And this work product will be moved forward into publication next month. And it represents a very thin layer of additional requirements over those CDA documents, really, as Bob pointed out, removing some of the optionality. Removing some of the optionality increases simplicity and makes sure that some critical elements needed to associate the attachment with the claim, the referral request, the prior authorization request, or the audit, those critical pieces of information are aligned, present and aligned. So under these guidelines, it's possible to send very simple attachments with less than a dozen data elements expressed in XML. And then the body of the attachment can be very simple, as you see in the case studies, a PDF, to very sophisticated, sending structured and coded data that is supports a greater level of automation. So I think with that, we can move forward, and I'll just give a brief, really quick introduction before handing it off to Nicole. So I'm going to introduce Nicole. She's going to give the first case study from mine, and then I'm going to come back and talk about the early case study from Mayo, and then hand it off to Mary Lynn. So the next slide just gives you an overview of these, and you can see there's a variety of approaches represented, with the first using PDF for the attachment, and then subsequent ones using the HL7 CDA. And with that, it's my pleasure to hand it over to Nicole.
Thank you, Luar. And welcome everyone today. Just to give a brief overview before we get into the case study on Vine, we are a provider of secure health information exchange, and we serve dental and medical providers and payers, essentially enabling them to connect disconnected data or closing the gaps in documentation while improving financial strength. So we have a technology platform that facilitates the secure electronic capture, storage, and submission of healthcare data, essentially in any format. So we can capture voice, fax, image, data, or electronic documentation. We work with commercial payers, but for this particular case study, we will look at CMS Medicare and Boca Raton Regional Hospital. Boca Raton is a 400-bed not-for-profit hospital serving a large Medicare population. Actually, more than 65% of their patient population is Medicare. And so as a result of that, they had a high volume of requests for medical documentation from Medicare to support claim submissions pre and post-payment. So for this case study, Boca was submitting solicited and unsolicited documentation in an unstructured PDF format. And they were submitting that documentation, whether it be for a claim attachment, an audit, or an appeal. And all that documentation was being transmitted through a Connect gateway via HTTPS. And essentially what they were submitting was an entire patient's medical records. So very large files were being sent in this PDF format. One of the benefits of sending electronically is they were able to receive a response and an acknowledgement from the recipient. So CMS, Medicare, or the actual reviewing contracting or contractor auditing entity would return an acknowledgement back confirming receipt of that documentation, which eliminates some of that administrative burden as well. And from a volume perspective, in 2016 alone, Boca Raton submitted over 1 million pages through electronically for these particular use cases. Next slide. And we'll take a look here when the slide advances at a high-level workflow for this process. For a solicited fashion, Boca Raton would receive a paper request letter for medical documentation, whether it be for a prepayment claim attachment or a post-payment audit. They would gather up all of that required documentation that's going to support that claim in a PDF format and submit that to a health information handler. And a health information handler is actually an organization that has been certified by CMS to handle health information on behalf of a provider. And so typically a health information handler, an HIH, is going to be a vendor that specializes in secure document exchange. They have built that Connect gateway to enable them to securely talk to CMS. They have 100% secure electronic delivery and a means for the provider to securely capture and transmit those medical records. So once the BOCA would capture that documentation and submit that to their HIH, the HIH is sending that through that Connect gateway via HTTPS onto Medicare. And then Medicare in turn provides that information to the requesting auditing contractor, whether that be a RAC or a MAC. Now to close that loop, again, that RAC and MAC would return acknowledgement back to BOCA. So they had peace of mind that that documentation was received in a secure fashion and a timely fashion. So essentially this electronic participation enabled BOCA to electronically track all of their submissions and documentation sent through this Connect gateway and eliminate any penalties associated with untimely filing. Next slide. And as we look at some of the challenges here, the majority of the challenges that we faced were on the back end. So they were completely invisible to the provider. In the beginning, this program with CMS, they did have some file size limitations imposed for documents being transmitted through that Connect gateway. And as I mentioned before, the provider is oftentimes sending an entire medical record, which usually is hundreds and sometimes thousands of pages. So when you're submitting that documentation or binary data through HTTPS, it must be encoded, so a base 64 encode, which increases the payload by as much as 30%. So as an HIH on the back end, we would have to repackage those submissions into smaller packages to get them through that Connect gateway. Again, this was all invisible to the provider. This was all back-end challenges that we had to work through. CMS has since increased that file size limitation, so it's not as big of an issue anymore. But those were some of the challenges that we faced initially. Since participation in 2012, BOCA has saved more than $3 million with these electronic submissions. They've improved their financial outlook because of more timely reimbursements on any of those solicited claim attachments. Prior to this electronic submission, 90% of their submission process was a manual paper-based process. So it was very timely, very cost prohibitive with these, they had untimely submissions. It was very manual process in human capital and daily monitoring of the documents that were submitted via manual paper-based processes and resubmitting that documentation. All of that has been eliminated since they've converted over to these electronic submissions. And additionally, as I mentioned, the reimbursement time, they've received payment in as little as 5 days on those claims as opposed to 4+ weeks with their paper processes. So overall, it's been a very successful program for Boca Raton, and they've been able to really eliminate the administrative burden of managing that flow of medical records, and it's resulted in some tremendous savings for the organization. And Leora, I will pass it back over to you. Thank you.
And Leora, if I can just make a comment real quickly. Something that's really important here to note is that the ESMD project, the connectivity method that's used through HTTPS is actually core phase 2, core connectivity rule compliant. So thank you. I'll hand it back over to you, Leora.
All right. Let's pick up the story here with some work that began, was hatched in 2005. And if you remember sort of those intersecting curve lines, that was after the evolution began towards simplification in the healthcare standard approach to attachment. And it began between Mayo and WPS. WPS was at that time the Medicare contractor for the Rochester region. It started, I believe it started as a pilot, but it was immediately clear that there was no going back. It was tremendously useful on both ends of the transaction. So that continued through the life of the WPS contract as Medicare provider, and as Mary Lynn will pick up the story, it resumed when NGS Anthem took over that contract. So there's been throughout, so we have probably cumulatively about 10 years experience here in electronic standard attachments between Mayo, and what we've seen is that it has survived and thrived through a change in the payer and an evolution on the provider side in their clinical systems. So started in 2005, went into production the next year, serving Medicare Part D. At that time, it was limited to the Rochester clinic. Mary Lynn may have time to talk about how those Mayo is planning to expand that. These are claims, so limited to the claims use case. They'd use the 4050 version of X12. These were unsolicited. I love to talk about the type of CDA because it was semi-structured. So it's an XML document that comes over to the payer, and there's no semantic coding, so you don't have in the body of the document clinical codes for diagnosis and so on, but that minimal XML structure is tremendously powerful for analysis through text processing tools. So it's a pretty interesting thing that they started with there. CDA Release 2, they used a bulletin board system to send an async bulletin board, and this through the life of this project was for operative notes with the 2262 modifiers. This is a heavy part of the Mayo business, if you will. And so it handled all surgical claims. Let's take a look at this very simple orchestration on the next slide, please. So they were sending together the 837 and the 275 by agreement. They were sent separately, but closely related in time. In the case that a claim was pending beyond a 5-day period, it would fall back into the regular review process, but typically these arrived within a day, and that was the workflow. So very simple, very direct, and with minimal changes to their way of doing business. And let's look at the next slide to see some of the outcomes from that. So challenges that were identified: educating. Education is always a challenge with any kind of change. Training up the payer staff, the WPS staff, on the attachments and the benefits. Working with Medicare to determine the providers that they would use for what was initially intended as a pilot and just continued into production, and what type of claims. They talked about solicited versus unsolicited. They ended up working with unsolicited, as you'll see. The next case study used a solicited orchestration, and they needed to identify an expert who could help them with the CDA standard. They had success in saving time on the Mayo side, well, actually on both sides, the mailroom time, nursing staff time required to manage this volume of material coming in. It improved the workflow processes, usable across all lines of business, and they report that the adjudication was done within 1 to 2 days, and Mayo received payment on average 20 to 30 days sooner than in the paper process. So you can see why on both sides there was a unwillingness to walk away from this process once they had set it up. So WPS saw a reduction of more than an FTE on their side, and they had a very happy client from Mayo. So that is my summary on behalf of the WPS and Mayo project, which terminated only when the contract moved from WPS. So at this point, I will hand it over to Mary Lynn. Mary Lynn?
Thank you, Leora. The case studies that I'm going to talk about, I'll be sharing the Medicare studies and implementation. So these are all Medicare related, all three of them. Pre-National Government Services, or NGS, Empire Medicare participated in a WEDI CMS attachment pilot using the solicited model. The providers that participated in the pilot were Memorial Sloan Kettering Hospital, Montefiore Medical Center, and several clients of NextGen. Clarity was the vendor involved in the pilot, and they converted the X12-275 and the HL7 CDA into XML files that were delivered to a client-server application developed by Empire. The versions used for the pilot were the X12, 277, and 275 version 4050, and the HL7 CDA Release 1 version. The unstructured CDA was used for the clinical data. Next slide, please, Drew. The workflow for the pilot was for the providers to continue to send the 837 claim files to the Empire EDI gateway. If the claim required additional documentation, Empire would generate the X12-277 request for information, requesting the medical records. The providers would receive and interpret the 277 request, and they would respond with the X12-275 and the HL7 CDA. For this pilot only, the Empire Medical Review staff would view the medical records by accessing the Empire Client Server application. Next slide, please. The biggest challenge we encountered with the pilot was the lack of HL7 CDA knowledge and experience. Fortunately, though, there were HL7 members willing to answer questions for us and help us out, so that was a big help. The successes of the pilot included Empire identifying several recommendations for the X12 and HL7 standard development organizations. And these recommendations have assisted with the changes in the future versions of the guide. The pilot was considered a success since the providers were able to interpret the 277 request, create the 275 with the CDA, and Empire was able to process the claim based on the data received in the 275 CDA. Another success was that Montefiore Medical Center requested to continue to use the 277 request after the completion of the pilot. CMS did approve this request, and Empire continued to send the 277 request to Montefiore for a period of time. The ROI expectation was that this process with electronic attachment would decrease the number of appeals received by Empire, which would result in a decreased cost. Next slide, please. In 2014, NGS implemented electronic attachments with Mayo Clinic. As Leora mentioned, this was carried over from the WPS implementation. This is also a production implementation, and it was not considered a pilot study. NGS implemented the unsolicited model using the X12-275 version 6020 and HL7 CDA Release 2 only for claims that included the 22 or 62 modifiers. Mayo generates the semi-structured CDA with the operative note in the XML text tag. NGS and Mayo chose to implement the 6020 version of the 275 because this is the version that has been recommended to be named in the attachment regulation. We implemented CDA Release 2, which is based on the same standard that has also been recommended to be named in the attachment regulation. Mayo accesses the NGS EDI gateway using the SFTP protocol. And this is the same way Mayo, as well as all of our other trading partners, send their EDI transactions. Mayo has been in production for over 3 years and are sending about 3,000 attachments each year. Next slide, please. Mayo sends the 837 transaction to the NGS EDI gateway, and if the claim includes the 22 or the 62 modifier, Mayo will send the 275 with the CDA within 3 days. NGS converts the 275 data into an XML file and the OpNote data into a text file. This data is ingested into our imaging system. Since the NGS staff currently uses the imaging systems to view paper attachments, our internal workflow did not require significant changes. Next slide, please. Some of the challenges with the Mayo implementation include their migration to a new EHR system. This will require us to implement the consolidated CDA release 2.1. And as a note, this is the HL7 version recommended to be named in the attachment regulation. In addition, once the new EHR system is implemented at all the Mayo sites, they will add these other providers to the electronic attachment process, and they'll send the 275s to NGS. The successes of this implementation include Mayo has stated, as Leora said, that they're getting paid 30 days sooner than the paper process, and the number of appeals they request has decreased. The biggest success, in NGS's opinion, is that our provider is satisfied. In addition, this implementation, we have proven that the standards recommended to be named in the attachment regulation really do work. Since only one provider is in production right now for Mayo, we have not determined the actual ROI. However, we expect to see a decrease in appeals, decrease in denials, as well as a decrease in phone calls. And with the increase in interest in this implementation, we are working on a process to define the actual ROI. Next slide, please. Case study number 5 is the NGS implementation with clearinghouses. This workflow allows the providers to receive the benefits of electronic attachments without having to change anything in their workflow. NGS is currently testing with Japari Solutions and Zermed, and we expect to move them into production early next week. Japari and Zermed are implementing the unsolicited model for claims with the 22 or 62 modifiers. Like Mayo, they are using the version 6020 of the 275 and HL7 CDA Release 2. However, Japari will be sending the unstructured CDA with PDF files. They will also access the NGS gateway using the SFTP protocol. Next slide, please. The clearinghouse workflow has the ability to support many different solutions and doesn't require the provider to make workflow changes on their end. Japari can support receiving an X12275, a PDF file, or any other kind of documentation that the provider or another clearinghouse wants to send to them. In this flow, the provider will continue to send the claims and documentation to Zermed as they do today. Zermed will send the claim and the documentation to Japari. Japari creates the 275 with the embedded CDA and will communicate the attachment control number and the 275 completion status back to Zermed. Zermed will add the attachment control number to the claim and send the 837 claim on to NGS. Japari will send the 275 with the embedded CDA to NGS. Again, as with Mayo, the process is going to work the same. This information will be ingested into our imaging system, and the process does not require any significant changes to the NGS workflow. Next slide, please. Since this process was already in production for NGS, there really weren't any challenges to mention, but there were a lot of successes. So the successes include this workflow using the clearinghouses allows the industry to leverage existing IT investments and resources as well as connectivity, and all through industry collaboration. Also, since this process was in production, it's relatively easy for NGS to add trading partners or providers. Again, as I mentioned with the Mayo implementation, this proves that the recommended standards really do work. Our providers are satisfied. And another success is that the providers or trading partners send the attachment data through the current connections that they have with NGS. And it doesn't require them to use a different path or a different gateway. Everything comes into the same gateway as they send their 837s or 276 claim status requests, any of their electronic transactions. In addition, Japari and Zermed were able to be ready to test with NGS in about 6 weeks, and they plan on offering this option to many other providers. As far as ROI, again, NGS is in the process of defining a process to capture the actual ROI, and we hope to be able to share this information with you in the future. Okay, back to CAQH. I think Drew's going to do a poll.
Yes, thank you so much, Mary, and thank you, Leora and Nicole, for your presentations as well. That was some very, very helpful and insightful information. And so this brings us to our second poll question. Actually, we have poll question 2 and 3 right here before we dive into Q&A. And this question asks, would you like a deeper dive on certain aspects of the case studies presented today? If so, which ones would you like? And this is also a select all that apply. So go ahead and log your responses, and we will pause just briefly before I share the results, and we go on to our third and final poll. And the reason we're asking this is Jessica and I would like to know what education sessions to bring forward to our audience. We'll take just a couple more seconds, and I'll share the results. Okay, we'll close and share. So 53% of those that selected got the most attention here. Technical details of attachments and connectivity standards. 32% all of the above. Would like to hear more of everything, really. And 31% saying revised process flows, execution steps, 21% tracking results and ROI, and 17% indicating business drivers and buy-in for adoption. So I'll take that down, and we'll go on to our third polling question, and this is the last one. And this one asks, what would you like to see in future webinars related to this topic? And again, this is a select all that apply. And just like number 2, we'll pause just a few brief seconds for everyone to respond before we move on to Q&A. Take about 5 more seconds. All right, I will close this poll and share the results here. So the most popular one here, 75% saying technical dive on HL7 CDA and or HL7 Fire, followed closely 69% X12 topics related to attachments, and then a tie, 43% mix of healthcare and industry neutral standards, and also yet to be federally mandated standards, example LOINC. So we'll take that down and we'll dive into Q&A, and I'm going to pass it off to my colleague Jessica Porras to run our Q&A session. Go ahead, Jessica.
Thanks, Drew. Thanks, Drew. And so you know, if you have any more questions, just please add them to that questions panel and we will get started. So Mary Lynn, the first two questions I think are for you. The first question, it's on case study 3, Mary Lynn. So that was the first case study that you presented. And the question there is, how automated was receiving of the 277 and the response with 275 plus attachment?
I assume that's kind of like on the provider end. The 277, I'll try to explain our process. The 277 request, that transaction was created by Empire at that time and was based on the information from the processing system. So we had to map our internal request codes to the LOINC codes in order to create that standard 277 transaction. That was pretty easy. It wasn't real hard. They did have some help from some medical review staff, some nurse reviewers, that type of thing, with the clinical information to help me choose the correct LOINC code. On the provider's end, once they received it, based on those LOINC codes, they were able to pull the documentation needed to send back to us. I believe that the pull of that information for all of the providers involved was still a manual process. They didn't automate anything because it was a pilot. What it did allow, however, especially for Montefiore, is that it allowed the request, that X12277, to be directly routed to the appropriate department or place within Montefiore to pull the documentation and send it back to us. I know Montefiore at that point they had some challenges with receiving hard copy letters. They weren't always getting to the right people in time because, of course, there's a certain time period that they need to in order to send the documentation back to us. They have like a 30-day turnaround time, and they weren't able to meet that all the time, which resulted in appeals. So that's why this 277 process was very beneficial for them. Once they pulled the documentation on their end, they created the 275 and sent it back to Empire. And then, of course, as I had explained on the Empire side, when we received it, it was converted into XML files and loaded into our client server application.
Thank you, Mary Lynn. So I've got another question for you, and this is on the case study with NGS and Mayo Clinic. And the question there is, what events or actions are used to trigger the electronic attachment? In other words, how does the process know when it needs an attachment?
That's actually on the Mayo Clinic side, and it is based on the presence of the 22 or 62 modifier. So they have that set up in their system that when they create a claim or generate a claim with the 22 or 62 modifier, they know they need to send the operative notes along with it. So they send the claim in, and then they also send the 275 with the HL7 CDA embedded inside it.
Thank you so much. That's very good information. So the next question is, I think, for all the case study presenters. And the question is, can you describe resources needed to implement the 275? How long did it take in some of the pilots?
This is Mary Lynn. I'll start with trying to answer that one. The 275, the X12 piece of the 275 was relatively easy. It's a pretty easy transaction. It wasn't difficult to implement. There were, like I had mentioned, there were definitely some challenges with the HL7 standard, and mainly because of the lack of knowledge and experience, at least from a payer perspective. A little bit different on the provider side. The providers and the vendors have a lot more experience and knowledge with HL7, but as a payer, we did not have that. So we needed to reach out to some technical folks who did have that information to assist with some questions and a little bit of guidance on how to implement things. The time frames for each case study was a little bit different, but like I did mention, once we implemented the 275 with CDA Release 2 for Mayo Clinic, it's in production, it's ready to go. We didn't need to really do anything. There were just a few little changes we needed to make for Japari and Zermed. So nothing major. It was pretty easy for us to implement it since we already had it implemented. And right now we are working on the consolidated CDA release 2.1, as I mentioned, because of Mayo migrating to a new EHR system. So right now we're working on those technical requirements. So we've kind of implemented in phases using, again, all of the recommended standards that we have been recommended to be named in that attachment regulation.
Thanks, Leora. Does anybody else want to comment? If not, we'll go to our next question.
that was Mary Lynn. You give
I'm
me so
sorry.
much credit here. It's all right. Thank you.
Well, then Mary Lynn, please stay on the line because the next question is for you. It's another question for the NGS case study. So how long did it take for the NGS, Japari, and Zermed implementation? So that was the last case study. We want to go to that slide.
All right. From an NGS perspective, like I said, there were a couple of changes we needed to make. I think maybe it took us from start to finish to create the requirements, have our vendor make the changes, and complete the testing maybe 6 weeks or so, 6 to 8 weeks. And then from the Japari Zermed side, didn't even take them quite 6 weeks to work together, collaborate, get their flow in place, and be ready to start sending test files to us. And it was going on at the same time.
Wow, thank you so much. That's amazing. Very, very fast implementation. So that's really great information. Nicole, this next question is for you. So for the Boca Raton example, did you consider passing the medical record in the CCDA standard format for exchanging EHRs instead of a PDF? Was that ever part of the consideration?
Well, since the participation was with the CMS ESMD program, at that time ESMD was not accepting a CCDA format. They are in pilot mode for that now. So the CMS requirement at that time was PDF.
Thank you so much. These were really great questions, and unfortunately we are out of time for today, but you know that if you do have additional questions, you can always email us at that core@caqh.org, and we can continue to assist you with any of your questions and even work with the presenters if that would be helpful. I would like to thank our speakers, Leora, Mary Lynn, and Nicole, as well as thank you, our audience, for taking time out of your busy schedules to join us, especially those of you in the lunch hour. As a reminder, links to the webinar slides and the recording will be emailed to all registrants and attendees in the next few days, and they will also be available on the website if that's easier for you to access. Here is a listing of our upcoming events. And please stay tuned for an announcement regarding the third session of our Attachments webinar series. And as always, we send out promos and you can register via our website. Also, finally, take a look at some of our e-learning tools. We are in the process of coming up with a couple new ones to try to get you the information that you need. And thank you again. Please keep in touch with us and enjoy the rest of your day.